This week, I sit down with a very special guest, orthodontist Jennifer Salzer, who is based in New York City. Jen and I share many patients together over the course of past decade or so. And what I enjoy about working with Jen is that she treats patients beyond just where their teeth are and where they could be. She really looks at the patient as a whole, their skeletal position, their airway, and their systemic health, and how it all ties together in the treatment of orthodontics. I think it's something that is important to note when you're moving teeth that actually has an impact on the whole system. So in this talk together, we'll focus on, in general, what is orthodontics, how does it work, the different types of interventions from braces to clear aligners. We'll touch upon your skeletal position and how that impacts your airway, and some of the considerations about the treatment and the impacts of treatment and timing of treatment. Commonly, we'll get questions about when should my child get orthodontic evaluation? Should we wait for they're 7 or 8 or in their teenager? So we try to go down what the impacts of different timings are of treatments for adults and also children, hoping that you can give yourself a little better understanding and knowledge base of the impacts of different types of treatments, and also some things to consider when receiving orthodontic treatment beyond just where your teeth are and could be. I hope you enjoy this as much as I did. Thank you for listening. I guess patients don't understand at any level, from my observation of patients, what orthodontics is and what it's really doing. So I think it's a great place to start of how are we able to move teeth and what are we doing when we put either brackets and a wire or clear aligners on someone's teeth, maybe like the short version so we don't.
Sure. So there's 2 components to moving teeth. One is moving jaws and the other is moving teeth. And we kind of have jurisdiction over both when people are growing. When they're done growing, we can only move teeth. But we do have influence over children because we can move their jaws much more easily. Obviously, we can make things wider, bring things forward. Orthodontics in general is the ability to move teeth, because when you move teeth, the bone and the gum move with the tooth. And that was found out many, many years ago. It was a great discovery that if you put pressure on a tooth, you're not just moving the tooth without the rest of the supporting structures. So teeth can be made straight, and it's much, much more than that. That's the thing I think people don't realize about orthodontics. If a dentist says to a patient, you can use orthodontics, I don't think they're realizing the scope of what orthodontics really covers.
Yeah, I agree. So right now there's a couple different options for treating patients, right? Like we mentioned, wires or clear aligners. I guess, what are the difference between the two, and why might you use one over the other?
So the way you move any tooth is with a combination of pressure and time. Right? So you need to find out a way to put a pressure on the tooth and the amount of time it takes for the tooth to respond. The traditional way was brackets and wires, whether on the outside of the teeth or on the inside. The bracket is just a handle. It's just acting as a way to grab the tooth. It's the wire doing all the work. So the wire goes into the bracket, puts a pressure on the tooth moves. When Invisalign first came out 20-something years ago, the premise behind it was that pressure in any way can move the tooth. So the series of plastic aligners was the way to translate that pressure to the tooth. And it's amazing how far it's come and the scope of what kind of cases we can treat with Invisalign. The problem is the time piece relies on the patient's compliance. So if the patient's not wearing the tray and it's just sitting on the nightstand, the time piece isn't there. So.
Can you move a tooth differently with a bracket versus a tray, or would you say they're at this point comparable, that if the compliance is 20-something hours a day with the trays, are you somewhat equivalent?
Mostly equivalent. There's certain exceptions to that. Like, for example, this would be an obvious one just from a mechanical standpoint. If you want to pull a tooth down and you put a bracket on the 2 teeth next to it and a bracket on that tooth, of course, when you put that wire in, there's a constant pressure pulling the tooth down. But if you put a tray on that tooth, which has the programmed movement down, but it's not really grabbing that tooth, maybe you put an attachment on to help, but it's just a more difficult movement to translate by just holding onto it with a tray. So most movements can be done pretty equivalently. Certain movements are a little harder with one versus the other.
With movements, so you mentioned a vertical component of a tooth moving up or down. I guess there's a few other types of movements, right? Your patients who are crowded are one thing, like tipping and tilting versus someone who might have some lateral incisors that are rotated.
Right.
I guess, how are you looking at that when you're evaluating a patient for Invisalign or braces, or just the movements in general? Someone says, oh, I have some crowding versus rotation. There's different amount of times that are involved, I guess.
Time and thought process. That's a great point. Like that, I think orthodontics as a specialty has to think about maybe more than the other specialties, which is the three-dimensional piece. Yeah. So not only the three-dimensional piece in the movements, like you just said, rotation, tipping, torquing side to side, but in the head, moving a jaw this way, rotating, leaning. I guess oral surgeons deal with this a lot with jaw surgery, but orthodontists deal with it on a micro and a macro level, the teeth within the jaw. And you have to put more thought process into it, because if you're moving a tooth this way, what is that doing to the overall picture as well? Is it changing the bite? Is it making the joint meet differently? Is it making the profile look different? So there's really so many levels of steps. And that's why just walking into a Smile Direct Club or something we're going to hit on later is problematic, because they're not looking at those things. They're really focused on one movement.
There are different ligaments around the tooth, right? The tooth is held into a bone with a ligament, and there are different angles that the ligaments actually go into the tooth, all different angles, right? So I guess when you're moving a tooth in a different way, you have to combat and reprogram the ligaments. Does that matter so much?
It doesn't matter as much in the movement part. What that matters more in is in the retention of what your movement was. So if you did a rotation movement, and you can imagine those ligaments holding on to the tooth all around, and then you turn that tooth, and those ligaments kind of want to pull the tooth back. So certain movements are less retentive friendly, and so you just have to build that into your way of holding your result.
I think the question I get most frequently from patients, once we have the conversation that, okay, you'd benefit from orthodontic treatment, it's always goes to, I'm sure you get it, is how long? Okay. Everybody wants to know how long. Yeah. So I guess if someone's listening to this at home and their teeth are crooked and they want to straighten them, what's a good way of understanding how long it takes, or does it matter? Right? Because everyone wants to wear the trays for the least amount of time possible.
Right. It's so hard to predict. I think, someone like Dr. Lemchen, who's been doing this for so long, people who have been doing it for decades, they have a better sense of being able to predict a timeline. It doesn't always go just by what you're looking at in the teeth. You have to take so many other things into account. But for patients in general who have crowding but a fairly good bite, we usually say it takes about a year to get where we want to go. That's with perfect compliance.
What would you say are the clear aligners over the wire treatment for you? What would you say are some of the best things about that for people? For me, of course, it's the aesthetics, yeah. Right? It opens the entire conversation up for patients who would never consider it.
That's very true. I mean, think of all the people who wouldn't have the beautiful smiles they have now if it weren't for Invisalign, because they just flat out would never do braces. It's so funny to me, over the time of, using both appliances, 20 years plus, it's like picking a favorite child. You can't, because I like them for different reasons. What I love about Invisalign, besides the aesthetics, is that it doesn't cause collateral damage. There's no gum swelling. There's no decalcification. There's no wearing down of the teeth that sometimes happens with brackets if it's not carefully managed, where someone's biting into their brackets, and you take off your aligner and you look brand new. Yeah. Whereas the day you take off braces, it's a little, if the kid didn't brush well, or if the adult didn't take great care, there's a timeline until it looks great.
Right.
So yeah. I love the pristineness of that. I love the predictability of braces over Invisalign, of course, because I'm in control. I'm not relying on the patient. So there's pluses and minuses to both, and I couldn't pick. If I had to practice with only one, if you said you can only practice with one for the rest of your life, I'd pick Invisalign or aligners. Yeah. I'd have to.
Right, because the patients are motivated and the
right results patients are so good. Yeah. They really are. You get to see it the whole way. I can see what's happening. The braces do obscure your vision of what's happening in some way.
That's interesting. I'm a prosthodontist, as you know, and I don't move teeth with braces. I move teeth with drill. Yeah. But I can see in the marketing of the companies I deal with, there's a couple different companies that make clear aligners, right? Aside from Invisalign, there's 3M and Dentsply. Mm-hmm. I'm not sure who else, but I know there's a couple different. Would you say, I would think there would be, but is there a big difference between the different companies, or would you say they're all kind of similar?
Most are similar. It's probably similar to you using different companies for 3D imaging. It's like you want the imaging software to be easy. You want to be able to control it.
Is it the car or the driver? You know
Yeah,
what I'm saying?
that's
Right?
that's what it is. It's
Yeah.
it's like you can give me any imaging software. If I'm allowed to move the teeth, I'm going to get it to where I want it to be. Of course, Invisalign has the time behind it where it's so tried and true. They're used to all the problems. We tried to start our own aligner company, and it was very difficult. We really came across a lot of problems. It was a great premise, but it's not so easy. So when you're there first and you're the best,
Yeah, of course.
you have the best software and all that. But we use other companies' products as well. It's the aligner is just translating the vision, exactly like you said.
Yeah, the driver probably matters the most. On that same topic, we should be rich right now and have shorted Smile Direct Club. How do we not? Right? I mean, like
We did. We didn't short it, but we knew.
So Smile Direct. Maybe tell people who don't know what Smile Direct Club or these at-home aligners were.
I mean, it was a great idea, for them as a business model, which didn't work out. But the idea was to try and bring straight teeth to the masses. It's not always so easy to go to a really great orthodontist. Wouldn't it be so easy to go to the mall and scan your teeth and get something sent to you?
Right. So how did it work?
Right. So what Smile Direct Club and the premise behind all of these things is that if you have easy availability to a scanner, you can make a 3D model of your teeth. And from there, any technician can straighten the teeth on the model and create aligners. So this Smile Direct Club, what it was basically was a do-it-yourself. Not so much. I mean, they did have some supervision with dentists, but it was a way to get straight teeth for people who didn't want to have to see an orthodontist, pay an orthodontist price, visit the orthodontist every 6 weeks. They just wanted to have the trays made and sent home, and I could just do this myself.
At home with no supervision.
Correct. So
Right.
You would go to a center or a place where there was a doctor who would scan your teeth, make some sort of treatment plan, but then another person somewhere else, another doctor that was hired by the company would be doing all of the 3D modeling. So let's say you got scanned and your desire was to straighten your teeth, but no one's really saying, oh, but your teeth don't show enough. I kind of want to lower them so I could see them more in your smile. So a stranger who doesn't know you or know your face would be doing the setup, and whatever you get, you get. You get them sent in the mail. Maybe they fit properly. Maybe they're going to move your whole bite. Maybe they're going to cause an interference. Maybe you're going to have a TMJ problem, but we don't know. How would you know if you're not being supervised?
So I guess one of the issues with Invisalign or clear aligner therapy is sometimes the teeth don't track.
Yeah.
Right? That's probably the biggest complication that you have to deal with. Maybe, I don't know.
A more worrisome complication is changing a bite. Right. So we're not just moving teeth. When you move a back teeth even one fraction of a millimeter, you're changing someone's bite, which relates to their jaw, their posture, their neck. We'll get much more into that later, I'm sure. But it's not without its landmines. I mean, you're taking on a case. Every time I take on any case, I'm responsible for what's going to happen in that case. So if you're just doing something, do it yourself, and something moves, who's going to save you when there's now a more troublesome problem? What you said about aligners not tracking is more of a minor problem in that you're not getting the translation of what you wanted. So you have to go back and get it. But it doesn't really cause as many problems that are dangerous in nature or worrisome.
So with Smile Direct was a pretty cheap solution for orthodontics, and with you and I being on the Upper East Side, we aren't fitting with that exact patient profile sometimes. But I'm sure you've seen plenty of Smile Direct patients over the years. What were a couple of the biggest problems? So you mentioned it was bite changes.
Well, just to mention back to the person doing the 3D imaging on your case, a stranger, this person was also doing thousands of cases a week. We know that now. We know how many, thousands of cases a week. So minute after minute, I mean, the time that we put into setting these cases up, the person was spending seconds doing it. So patients that would come to me that had used Smile Direct Club and now have a problem would have teeth that weren't even straight. So I went through all this. I spent the money. My teeth look worse. My teeth look different, worse, a different kind of crooked. My bite doesn't close now. I used to have a comfortable bite. Now when I go to close, no teeth touch. My jaw hurts all the time. My neck hurts all the time. I have cavities between my teeth. So many things.
Yeah, with the lack of accountability and the lack of supervision, I mean, it's a crazy idea.
Well, look, Rob, to me, from what I know from working together with you over the years and all the patients that you have, you know everything about them. Like you really do. Right. When I see your patients, they're amazed by how much involvement you have in their life. They love it. And it's amazing. They're lucky, right? Our patients are lucky.
And so are we, right?
We are too.
Yeah.
That's why we're doing this so many years. But when I see a patient, even just for the first time, you sent me a patient recently, a male patient. I saw him only once in person. And then we did the consult online. And then I got his movie back about what his teeth. And without even knowing him, except for this one time, I automatically knew that the setup that they did, Invisalign, and no blame to them, they're just doing what they're told, was completely wrong for his face. It was like, I almost wanted to do a post about it. Like, imagine if they had really done this, what would have happened to this guy's smile? How can you know that if you don't have the knowledge base and the experience? Forget being able to see the patient and know what's right for them after one visit. It's just the knowledge base. It takes you years, like Malcolm Gladwell said, 10,000 times to be an expert. These people were doing it fresh out of the box. There was no expertise or knowledge. Would you put your child in that person's care?
Right. It's
dangerous.
You get what you pay for, unfortunately.
Worse.
Yeah.
You get less than you pay for in this case.
I guess we should double click on that. And so before we started recording, you and I were talking about the current landscape of dentistry. It's changing a lot. Right, a quarter to a third of all dental practices are owned by a group now, private equity or DSOs. And with that, I find, and I know you find, especially in orthodontic more than any other part of a specialty, is that generalists are doing the treatment. So I know we're going to go down a different rabbit hole here, but I think it's worth it. And so if you look at the literature around root canal therapy, where a specialist does it and a generalist does it, right? Toronto study, a big study around survival rates of teeth. So when a specialist does a root canal, 10 years, you have more than 90% survival rate of those teeth. When a generalist does it, you have a 50% survival of those teeth. It's a huge, huge disparity. What a difference, right? So we could talk about generalists doing treatment versus orthodontists. What are your thoughts around that?
I'll tell you, from when I started practice 25 years ago with Mark Lemshin, one of the things he always said, and he's right, if you're not doing it all day, every day, you're never going to get great at it, right? So we know that. So, for example, he started doing linguals, inside braces, 40 years ago, whatever it was. We do it every day. We do linguals every day. We don't see special lingual patients on Saturdays. We don't do special time slots. We don't do it once a week when the expert's there. We see lingual patients all day, anytime, 5 days a week, right? 6 days a week. The point being that a generalist is so busy doing all of the other things that are so important for dental health.
Right.
They're finding cavities, they're doing cleanings, they're doing crowns, whatever they're doing. If you're not doing orthodontics all day, every day, you're not going to see the trouble spots. You're not going to go down those paths that we went to figure out what doesn't work, what goes wrong. And you know, that's why I don't do veneers. That's why I don't do whitening even. You know, I'll give someone some foam for a tray, but if they want a whitening treatment, I never bought a laser. I could have had a Zoom machine and gotten money that way. I never did it because I don't know enough about it.
Right.
And that was your job. You know, I send them back to you for that. So I just feel like a generalist might have somewhat of a knowledge base to understand orthodontics, or even if they just want to move a tooth a little bit to help their restoration, that I think is okay. In fact, I was one of the first people decades ago to train dentists to use Invisalign. That was very controversial at the time. Align came to me, they said, we like the way you train this, we'd like you to train dentists to do it. There was a whole lawsuit where dentists sued Align because they wanted to be able to use Invisalign to help their restorative goals. And I felt strongly enough about it that I trained thousands of dentists in New York City. Many of your friends can say, that's how I got certified. Dr. Salzer certified me. So I felt that it was okay to have that amount of knowledge base. And it's okay to move teeth slightly if it works for the whole plan. But when you get involved with something that's out of your scope, that's where the danger zone is.
Comes down to everything is knowing your limitations.
That's it.
Right.
That's it.
Know
your limitations.
Right. With every type of dentistry, even
Right.
even root canal, basic root canal, general dentists can probably execute very adequately.
Right.
But as it becomes more complicated, so patients beware. On that same topic, if someone, part of our recordings here, my goal is to connect with patients anywhere that they may be, but who cannot come to us because of geography or finances, whatever it may be, and who are trying to take great care of themselves. So how would you recommend someone who lives somewhere in the country find the right orthodontist for them? What's the best way to do that?
I mean, the traditional answer over the years was board certified, years of experience, reviews, websites. It's a very hard situation because there's so many components to it. It's not just being a good orthodontist. It's being a little bit out of the box these days. It's not just saying, hey, you have perfect straight teeth. Look how great your models fit together. I'm the best orthodontist. I got an A+ on your models. Well, that's in your head. So what if it looks bad because it's pushed too far back? What if it encroached on your airway? What if it caused TMJ, internal derangement? There's so many different components to it. I think, unfortunately, patients have to use their gut instincts, like you might have mentioned before, of a good fit for them. If your doctor is not listening to you and hearing you, that's already not going to work.
Number one.
Yeah. I do think having a board certified doctor is a smart way to go. That's always reliable.
What other things would someone look for? So if they go, call a few offices, what are things that you would say that they should look for in the office and through that first consult appointment? So let's say I'm going to try 3 different offices. Right. I'm going to consider a surgery or something, whatever it may be. And these things are probably overlapping for not just orthodontics, but for any type of medical care. Yeah. But specifically for orthodontics, what would you say going through their initial appointment and the consult, what should they look for?
Okay. So for sure, thoroughness. This is the type of situation you go to an orthodontist or any, doctor, and you say, this is my problem. And the doctor says, oh, great, I can fix this. You need Invisalign. They didn't look at your x-ray. They didn't talk about your medical history. There's so many layers to that. So the doctor needs to be thorough and have a basis for understanding what your problem is and how they're going to solve it, not just a catch-all, braces will solve this. Show me what the problem is. What's wrong with my bite? Where's the side view of my jaw structure? Is my jaw structure involved in fixing this bite? So a person would have a much more thorough consultation. And that's one of the reasons why all of these years I do my own consultations. So I don't have a TC, a treatment coordinator. We don't have a person that just sits down with the patient and says, your child needs a palate expander. This is why we do it ourselves. And Dr. Lemshin and I realize it takes a lot of our time. They're half an hour each. This is a second visit after the main visit. But we find that solves so many problems and questions later on because we took the time to analyze the problem and really explain it. So I would say if you're seeing an orthodontist, you really need a lot of thoroughness to it. It's not just like, hey, let's get started. We're going to put the braces on today. No. Another thing is a sensitivity, to hearing what the problem is and understanding that this is not just aesthetic, that there might be a health benefit to this as well. And then, of course, the office culture, the cleanliness, the technology, these things are very indicative of what kind of treatment you're going to get.
Right. So technology should be an intraoral scanner.
Intraoral scanner, cone beam, 3D X-ray,
the 3D,
I believe.
3D CAT scan.
Yep. The 3D CAT scan gives us so much information, just like it does for you. So for orthodontists, it's almost like triple fold what you get. So you get many different views. You get a panoramic view, you get a side view to analyze the profile, the jaw structure, the joint, an entire joint workup, an airway study, which we take on every patient, age 5, age 90, whoever's coming in, they're getting an airway study. You can see the nasal structures, the adenoids, the tonsils, the size of the throat, everything nasal septum wise. You can take this analysis to such a huge level. And then, of course, the 3D scan. There's no molds anymore. These things are antiquated.
Right. Yeah.
And there's much more technology beyond that. Facial structure recognition, and this could all be married together, where you get such a better diagnosis and treatment plan.
Yeah. So go through a few different offices, maybe consider a couple of different orthodontists and really evaluate the office, the energy of the office, the attentiveness of the people at the office, and then the technology and the attention to detail would be a couple of things that you should really pay attention. And that's any doctor.
Yes.
I've known you for a long time. Aside from being wildly brilliant and smart, the thing that strikes me about you is your energy and your state and the way you treat patients. So aside from being analytical and intelligent and really careful, you're also warm, optimistic.
Oh.
Yeah.
That's all I want to be.
Right.
To be honest,
right.
I would take warm and optimistic over anything else.
Yeah. Right.
You're born that way, I think.
So I think it's an interesting conversation, and this is so kind of off topic in a sense, but in knowing you, especially the past 5 years, you've had a lot of challenges in your life. A lot of things from your house to some health issues with your children, to yourself. I mean, and I think that we're all professionals and we're all working hard at our job, and we all have a job where we're sitting across from somebody, or whatever you're doing, whether you're a lawyer or anything else you're doing, a teacher. We all have really tough things that happen in our life, and I could tell you that your stride hasn't slowed down through any of that. How would you say you've done that?
So
I know it's a little
no.
Yeah.
I love it. I think it's, first of all, I feel lucky. I do feel like genetics made me a happy person. That's I feel bad for people who don't have that disposition, and that's just a thing. Second of all, grateful. So what you were alluding to, and my kids having some health problems and everything, thank goodness, is fine. And I saw in them a resilience and like I don't want to say not botheredness, but like just such a great approach to it that I said to myself, why am I suffering so much with anxiety and fear and all of this if they're the ones who went through it and they're not even feeling that way? Right. So, and then I started to realize that everything really happens for a reason, which we all say, and we kind of like, that's a saying, but it really happened to me to find that out. So for example, my daughter had thyroid cancer at age 12, out of nowhere. You know, here I was thinking that I had a very healthy family. I have 4 beautiful children. She had thyroid cancer. She did great. She had a full thyroidectomy. Perfect, all good. By the way, the support of the doctors, number one. Like, I found the best people, and they were just, that's a whole other discussion. But recently, one of my favorite patients who sees me from Canada, she's this unbelievable 20-something-year-old, gorgeous singer, the best attitude, the most positive person, loving and positive, came to me and told me that she had thyroid cancer. This just happened.
Oh, wow.
And when I tell you the joy I felt, I got her an appointment at my doctor at Sloan Kettering. It was almost impossible. I was with my husband at dinner. I started crying. I said, Dr. Wong's going to see her. We got an appointment for her. He's like, calm down. No, he understood. The fact that I could parlay what happened to my daughter to help this girl, I can't explain it. It was like one of the best feelings.
Yeah.
And not just because I don't get any benefit from it. I'm just happy for her that she doesn't have to be as scared. So I just feel like things happen for a real reason, and they're like tangible steps. And I guess I've been lucky enough to see that cycle through, you know, the benefit of it. So I guess that's why. And it's genetic. I can thank my mom and dad.
Yeah, exactly. It's pretty good, right? So with that, one of your children, when he was 5, you noticed some pictures of him.
Oh, yeah. My first son, even younger than 5, his baby pictures. Every picture, his mouth is open.
What did you see in his photo?
I just thought it was, at that time, I thought it was like, oh, that's so cute. His mouth is never closed. It was weird. You don't see, I always tell moms now, you're going to look back and you're going to be like, every baby, look at Michael Phelps' baby pictures. Every single picture, his mouth is open. Every single picture, because he couldn't breathe through his nose, I'm assuming. So my son, my first son, cute baby, mouth always open, breathing through his mouth. You know, some health issues, tonsils, adenoids, that kind of thing. But I realized pretty quickly, because I had jaw surgery, so I was very sensitive to like jaws growing wrong.
How old were you when you had that?
I was in dental school at the time. And I didn't know my whole life why my lower jaw was so small, and I didn't look like my sister, and she had a much bigger smile. Like, I didn't really realize, I didn't put the dots together until I was in dental school. That's a whole other story, which is a very funny story, but we could say that later.
Okay.
So I'm seeing my son growing up and young baby, having like that same kind of look. Like, why does he have these dark circles under his eyes? Why do I see the whites of his eyes? Why is his nose always crusty? Why is his mouth always open? But nothing I had learned in dental school at all, in ortho school, had taught me about how to control this vertical growth of the face. Nothing. So that's where I kind of went on this little wild journey of figuring out, why does a face grow long? Like, how can we stop a face from growing long? And how does that affect the aesthetics of the face and the health of the patient? So over the course of 10 years, using my son as my, I guess, guinea pig, I learned how to grow a face forward. Let's put it that way. Like, I would fly him back and forth to California to my guru, who was Dr. Bill Hang, who taught me how to reshape the face growth. And it was funny. First, I called him out of nowhere, out of the blue, and I said, my son's face is growing long. I want you to teach me what your appliances are. Just tell me what your appliances are. And he said to me, I don't do just. So I'm not going to just teach you. You either come and spend a year learning from me, or I don't teach you. I said, no, trust me, I'm really smart. If you just give me the lab prescription, I have a great lab, I can make it. And I learned my lesson. Like, that's not how it's done. Really, that's why you can't do a weekend course.
Right.
Right.
In anything.
So I spent 10 years using my son as my guinea pig, and he thanks me still to this day. He's a 21-year-old college kid with a gorgeous profile, the best of all my family. And he says, thank God you made me do this, because I love my face. Now, that's how I learned what I learned and took into the practice. It was very controversial at the time. No one was really doing that. And especially to be in this Park Avenue fancy practice. Dr. Lemshin said, you learn whatever you want and you bring it into the practice. He paid for it. That's why he's a wonderful person, because he allows people to learn what they think is important. And I've been able to tailor it to not be a fringe thing and not be like a wild thing that's dangerous. It's just part of the way I see all patients, that their jaws should be forward, their teeth should be forward, and that we shouldn't retract.
Yeah, so we were also talking before we started recording about the book Breathe, the book Jaws, and how often patients talk to us about that and bring it up. Mouth taping is all over TikTok.
Yeah.
And so there's a lot of people who breathe through their mouth, not through their nose. Mentioning how your son's mouth was open in all the photographs. And there are some beliefs and thoughts around why that may be. I mean, it could be, right, there's popular beliefs, or it's diet, the shift in the food becoming softer, less chewing.
That's evolutionarily.
Right. Environment, we're indoors more than we were, right? So maybe the air quality isn't as great. So there's a belief that, and the NIH still to this day believes that orthodontic issues are fully genetic. And then there's this other side of the coin where there's a huge amount of environmental component that contributes to teeth not being straight. I guess, given your experience, what are your feelings around the two of those, and patients who might present to you, children or adults, with benefiting from orthodontics, whether it's teeth malalignment or they're mouth breathers because they don't have enough vertical space to breathe? So
that's a great point, and it's a very interesting topic. I think all disease is a combination of both. And you can consider malocclusions as a form of disease. Now, being in practice 25 plus years, I've seen generations.
Right.
G1, G2, G3. For sure, genetics is a huge component of facial structure. So you have an underbite, uncle so-and-so has that underbite, missing teeth, you're missing your lateral. Oh, your mom has a peg lateral. This is like, we see this all the time.
We do.
You look like your family for a reason. So genetics plays a large role in skeletal structure. Environmental reasons influence that, of course, epigenetics. And they can influence it very strongly, where you see two twins and one has allergies and the other doesn't. And maybe they were going to look the same and they ended up not, because over time, the kid who breathed through their mouth only because they had no nasal airway, the bones changed and went down and grew longer. So it has a huge influence. The problem is, and you mentioned diet and Weston Price, and yes, that's over an arc of 100 years or more. But we're talking about in this child's lifespan, what can influence it, yes or no? There's so many little things. The nasal breathing is a big piece of it, huge piece of it. The lip closure is a big piece of it. But like my son, as in these formative years before he got really long, and then it was almost too hard to reverse, no matter how many times I said to him, close your mouth, I knew enough to say that. Close your lips, put the tongue on the roof of your mouth, breathe through your nose. He would do it for 1 second, and then a second later, he'd have to part his lips to be alive, to breathe. Because the length of his upper jaw was already such that in order to close his lips, there was an effort. So of course he let go. It wasn't just to breathe. It wasn't just to live. It was functional, comfortable, right? So I would take pictures of him. 1 second would be closed and the next second open. By then he had already grown too vertical to close it. So I had to push his upper jaw up to allow that to even change. So there's so many factors that influence it so quickly, right? That a parent has to be in tune to this almost at birth.
When I hammered for my son, I don't know, you told me this. We were talking about it.
Yeah.
I remember sending you videos of me closing his mouth as a little baby.
Sure.
I remember.
Right.
Look,
Right
I'm
after,
doing it. I'm doing it.
Right after
And
breastfeeding.
now he's fine.
Yeah. Think about indigenous tribes and the mother would be holding the baby all the time. You know, there's a whole system of that being part of why their jaw structure is good. But right after the baby comes off the breast, the mother should gently close the lips with her fingers. And these little tiny nuanced things can change the whole course of how the child grows. It's crazy. Yeah. So it's just the knowledge. I think people sometimes take it too far and, change the diet completely and worry. I don't think we have to worry as much. And we talked about that before we started as well, how the pendulum swings so far one way and so far the other, and patients get all wrapped up in this is all that matters now. The mouth size, the lip taping, this is all that matters. There's so much more to it. And people need to just relax, take a step back and learn, because this lip taping is not the cure-all. That can actually be dangerous sometimes.
Are people lip taping? I don't treat children, so I don't know.
Oh, I taped lips.
Are they taping their children's?
Before it became a thing, I should have branded my own lip tape. We were taping lips with BioBlock patients, including my son, 20 years ago.
Oh, wow.
And it was so funny because when you told a parent about it then, you're like, listen, don't tell anyone, but you got to tape your kids. It was weird.
Yeah.
But we would just put 2 little strips of 3M tape, no fancy, huge hostage thing, tiny little tape. And it's safe enough to break apart if they need to open their mouth at night, of course. But it just started to turn that ship.
Build that habit.
Build a habit. But with myofunctional therapy, with a clear nasal airway, with its lip taping, with the nose widening, all of these things would then alter that breathing pattern. But there's more to it than that. There's the lungs, there's the posture, there's the stomach versus the diaphragm breathing. And it's overwhelming. It's overwhelming for patients. Even this talk might be overwhelming because it's like, okay, now I have to get to this, this, and this. Everyone should just relax, just breathe. It's not as critical as everyone thinks.
For me, I work with patients around this, of course, and it's always, I start with them as just posture, right? Keep your lips together, your tongue on your palate. Start there as much as you can.
Start there. Breathe through your nose. Be aware.
When you're exercising, when you're walking, when you're reading, watching TV.
Yeah, Bill Hang has run many, many marathons with his lips taped. And he trained himself. He was a mouth breather. He trained himself. He ran the whole marathon only with breathing through his nose, many times.
So what would be some actionable advice for people who have children, maybe 0 to 6 years old, things they should look for? So their mouth is open, gently close it.
Dark circles under the eyes, sleeping disturbances. So moving around a lot. Every time you walk into their room in the morning, the covers are all over, the kids over there, the pillows there. So that's a lot of movement in their sleep. Crusty lips. Kids who have their mouth closed all night do not wake up with crust. Wet drool on the pillow. That's like a number one sign that I really see a lot. Behavior issues, ADD, learning disabilities. I don't want to, again, say that it's all from that, but a lot of these things can be traced back to it, if we really look through decades of cases. Facial appearance. A change. Where's my cute little daughter who had that perfect little round face and now she looks different? That happens a lot. Grandparents send patients to me a lot. They say, I don't want to say anything to my daughter, but my grandchild looks different and I don't really quite know what it is, but I heard you talking on Dr. Radio about this, that, and the other thing. I get those calls a lot.
So if you have a 1, 2, 3, or 4-year-old and you find they have some of these things, what can you do? What would you recommend?
Well, you do the little things like you said, the little small changes, like reminding them of how to sit up straight or keep your lips together, breathe through your nose, teaching them. Were you taught that? I didn't know the difference between nasal breathing and mouth breathing.
No, we were talking about how you and I have studied all this recently.
Yeah.
The dental school, they don't expose you.
I'm talking parents. Did your parents tell you? Close your lips?
Oh my God.
Yeah.
No.
That's what I'm saying. No, I'm saying as a 1, 2, 3, 4. There were the old mean parents that say, close your lips, you're going to catch a fly, or whatever that line is. They didn't know why, though. They just knew it looked weird to a kid sitting like this. Don't slouch. A parent would say that to a child, but they didn't know the medical premise behind it. But there's a reason why, right? Health is beauty and beauty is health for a reason. So I think these little things of just having the knowledge. So if you look at let's say a pediatric textbook for pediatricians, and it has all these diseases and conditions and cardiac, and there's probably 3 pages on airway.
Right.
But it's everything.
Yeah.
Sleeping and
It's
airway.
everything.
So if parents have a little knowledge, they can help their children.
So nasal breathing is a different quality of air, right? Physiologically, different things happen to you when you breathe through your nose versus your mouth. Maybe we should talk about that for a second, just to let people.
Yeah.
Right?
Well, on the most basic level, it's very simple. It's warmed. It's filtered with a little hair in the nose. It's treated. It's treated air. It follows a turbulent pathway. There's special shelves in the nose that change the turbulence of the air. So if you're a regular breather, I am. If all of a sudden I have to breathe like this, the air feels weird to me. I'm like, something's wrong. It's too present. It's coming in too fast. It's not right. So there's that little special organ of a nose that's put there to filter and treat the air. That's it. It's as simple as that.
Right. And then there's also things that occur in nitrous oxide development, which is so tied to cardiovascular health and also your nervous system.
Yes.
So that's one thing with patients who are anxious or children who have anxiety, who are breathing through their mouth, or ADHD, who are mouth breathers, not nasal breathers, is, I believe, a huge component. We don't have good literature around this at all. And that's part of the challenge with this topic, is that there are resources like the books that we talked about, Breathe in Jaws, but there are not a ton of great research resources that we can go back on to state, well, if you are a nose breather versus a mouth breather, here are the outcomes.
Right.
We don't have that.
Right.
So we're kind of working on the fly and trying to educate our patients the best we can. I know I am. I know you are too. Right. But we can definitely say that the way you breathe has an effect on your cardiovascular health.
Let's even put a step before that. Basic step. The way you breathe has an effect on your posture.
Yeah.
And that starts the whole, because even just the head forward, shoulder slouch is putting a compression on your sternum.
Trying to breathe through your mouth.
And your lungs. And even just having that opening of the lung, sometimes these children, their posture is so set that even if we do everything, scoop out their adenoids, teach them how to breathe, perfect, we did our job, they're still not filling their lungs to the bottom. And that whole anxiety spiral that you're talking about, the vagus nerve, it's so complicated, but it starts with something simple.
A friend of mine who's a dentist, a prosthodontist up in Jason Sauer up in Westchester with Lenny Coburn, one of his children were having some attention issues and behavior issues. And we sat in a lecture. This has to be like 10 years ago. And this is one of the first times we've heard this. Jason and I heard this. And sure enough, he went back home and he started watching his son sleep. And he noticed that it was breathing issues and sleep issues that were causing this. So he had to be 6 years old at that point. And so then he called up one of his friends, orthodontist there, and they started treatment. So I'd love to talk about this for a second. I was at dinner not too long ago, and one of the couples are asking me about their children, who is 7, 8 years old, and the orthodontist is proposing 2 phases of treatment, phase 1 and phase 2. And the wife is all ready to do this, and the husband says, but isn't it a little bit of a joke that we're doing it twice?
Exactly.
Really, we can get everything done at one time.
Exactly.
And so I'd love to talk about why we would want to treat somebody in 2 different phases from a skeletal development standpoint, and what the benefits are from you, because you are the best person to talk about. You get people who haven't had a phase 1 or they only have 1 phase when they're older, versus a phase 1 and phase 2. So what are we talking about for people who don't know what we're talking about? What does that mean?
So in the old days, let's say before there was a phase 1, the knowledge that we can do things earlier, you would just treat a kid once all their permanent teeth are in, right? So
around what age
12,
is that?
12 is usually the start of that. So I'm in my 50s. When I was a teenager, no one gets sent to the orthodontist before the permanent teeth are in. That's when you're referred. You wouldn't even know prior to that to even think about it. So let's use me as an example. If my mother had seen all those things, the dark circles, the drooling, the chin that was weak, recessed chin, if she knew that there was a way to fix that early, of course she would have done it. But she was told by the dentist to take your daughter to the orthodontist when she's 13, when all the permanent teeth are growing in. By then, it's too late. I have so much crowding, the teeniest mouth you ever saw. And of course, they pulled 4 premolars and put on a retractive headgear to push my upper jaw back to meet my deficient lower jaw. Great, right? Okay. Now, why do we do phase 1? Why would we even propose to start something earlier? Because it has been proven that you can move the bones, you can widen the palate, and you can do things skeletally when they're growing that you can't do once all the permanent teeth are in. So before I said, if I only had the choice to do braces or Invisalign, and I chose Invisalign, I lied, because really all I would ever do is a palate expander. If you said to me, I can only use one thing for the rest of my career, it's a palate expander. When a child is 7, 8, and 9, their suture of the palate is open. There's 2 halves to it. The middle is open. Of course, on you and I, it's fused solid. But when a child is 7, 8, 9, 10, you can open that suture and truly widen the palate, which is usually what people need. Almost everybody could use that. You can also bring the lower jaw forward. You could bring the upper jaw forward. You have so much ability to, even if the child is perfect in their jaw structure, you have the ability to fit more teeth in. And so phase 1 is really more of an orthopedic correction, which gets you a better result later on. When the kid is 12 and all the teeth grow in, we have less to do. We just tidy things up. So I would always choose the phase 1, phase 2 in the right patient. And it's not to make more money or put the kid through more torture. Yeah. It's to get a better result.
Right.
A healthier, better looking result.
And it's more, like you said, it's an orthopedic solution to actually get the skeleton in the right place.
Yeah. And to make more room to fit all the teeth, to make a bigger, broader, nicer smile. There's a lot of reasons. Not to mention the social aspect for the kid. Let's say a kid has a terrible bite, crooked teeth, and we're telling them now between the ages of 8 and 12, they should look like crowded teeth. And I mean, everyone cares about the social well-being of children. Let's let them have straight teeth also.
Right. Yeah, why not, right? You know, one observation I have from adults going through orthodontics that had traditional ortho when they were younger, like you're speaking about, right? When they were a teenager, they had ortho treatment, one phase, and then they had relapse. Later in life, they went through orthodontic treatment again, and now they're getting a dental implant. So what we'll do is we'll take a 3D cone beam image, like you said, a CAT scan, and those teeth look beautiful, but I could see where those teeth are in the bone relative to where they should be. And so to get those teeth in a perfect position sometimes, it requires them to be moving out of the bony housing. And you'll see this sometimes when you get patients from wherever they may have gotten their orthodontic treatment, anywhere in the country or here in New York, and you take a CAT scan, you're like, whoa, we've really got to be on top of this person with recalls and making sure that their hygiene is perfect, because with any recession, they're going to just unzip their gum tissue because, like you're saying, the older you get, the bone doesn't move as much as the tooth can.
By the way, let's talk about patients who had extractions like I did. And people would say, oh, well, at least that's more stable. The teeth are not blown out off of the bone. But you and I know they're leaned in towards the tongue, and they have just as much recession. Because instead of the tooth being over the bone that supports it, it's leaning in. So the root's coming out this way, and they have just as much recession. So it wasn't like it was the big cure-all for not having recession or problems like that.
Yeah, let's talk about that for a second. And maybe explain there's orthodontic treatment that you would have your first premolars taken out. So how old is a child when you do that treatment?
Usually 12, because now everything's erupted. The premolars erupt at 12. Mm-hmm. So everything's erupted, and whether the mouth is too crowded or there's an overbite that you can't resolve or an underbite that you can't resolve, you may steal those teeth to give you more room.
Yeah, the philosophy was that it was a room. You're making room.
It's like robbing Peter to pay Paul. Yeah. We got to get rid of these to fit in those.
Right. So in your opinion, in 2024, how many patients or what percentage of patients would still benefit? When do you still need to do that at times?
We still do. So I'm not I'm never a hardliner on anything, truly, but I'm not dogmatic, I'll say. So there are cases that could benefit from extractions. Teeth leaning so far forward, wildly off the bone that the patient can't close their lips, even if they were able to. We need to kind of bring things back so they can get a better lip seal. Granted, we check the airway before we do things like that. Severe crowding, which would set them up for a lifelong difficulty keeping their teeth clean and all this. So we still do it. It's just not as necessary because we're able to expand.
Especially with phase 1.
Right. So we have these tools that allow us to avoid that. It's better. It's better to keep what you were born supposed to have.
So a small percentage.
Yeah,
a very small percentage. On that same topic, keeping what you were born with, and it's a conversation that I have with patients all the time. And I'm so confused about this conversation.
Wisdom.
Third molars. Yeah, I'm so confused about third molars.
Yeah.
I'll tell you my perspective on it, because I maintain people through their life.
Right.
I have many, many patients who are between 70 and 100. I had a 98-year-old patient this week. Perfect memory. Remembers my children's names, their ages, everything. Amazing. Pretty cool. And so,
let's measure her airway.
Yeah. She's amazing. In taking care of patients who are in that phase of their life, third molars can become problematic. Some are completely beneficial and their third molars are perfect. Yesterday, we just took Cassie on a patient with third molars. We couldn't get an x-ray on them because she still has her third molars. They're great. She's like crowns on some of them and everything. They're still there. And some we just couldn't see the root and there was a little sensitivity. So whatever. But I'm treating a lot of patients who are 15, 16, 17 years old. And the conversation is, what should I do with my wisdom teeth? And I don't know.
Okay.
Right? I don't know.
Yeah.
I know that in most of my patients who do not have the clear room for them, they become a liability through life. So I'd say in the majority of my patients, I end up recommending extraction at a young age. But I'm confused by this because our body doesn't waste energy on anything. Right? Our body is a very conservative being. And so if we don't have to do something, we don't do it. Most of my patients have third molars. Right. And I'm so confused by this.
Okay. That's a great topic that would take us hours to really tease out. But evolutionarily, teeth start to become less and less present. People are born without third molars. Sometimes there's missing teeth. It would take generations for that to translate into, we actually don't need third molars. That's not going to happen anytime soon. So even though you're right that we don't necessarily need them because our mouths are smaller, and we know that from the research that if we look at a skull of someone from civilizations way back, it's broader, it's flatter, different. And over time, we look at mouths that are smaller, more crowded. That's what all these books that we discussed before are about. But it would take hundreds and hundreds of years for the agenesis or the non-formation of third molars to catch up with that. So the question is, I'm confused also. I get what you're saying. What do you do with them? Why do they not fit? And when do you recommend them coming out? A lot of people are saying, just take them out no matter what. I am not like that. And from our patients that we share, I'm very conservative on it, except when it blows up on them in college and now they have nowhere to go and we have a real problem. But we do find that, for example, I'll use my son Mason as an example. He had the smallest mouth. You could hold it in a teaspoon if you had an impression of it. I broadened it, brought it forward with all the processes that I told you before. All of his third molars have grown in fully straight. I never straightened them. They had room to grow in after this BioBlock treatment that we did. And it's a non-issue. But you can't say that if you make space, every kid with a palate expander is going to be able to fit their third molars, right? Because sometimes the butt of it just turns sideways before you have a chance. And once it's sideways, it's never going to grow in usefully. Yeah, so those we say, like you said, if it's growing in sideways, if it's putting pressure on the tooth in front of it, if it's going to mess up all the ortho, if it's going to cause a cavity, it's gone, right? But if they look like they're coming in fine and there's room for them, I would never take out a fully functioning tooth. Even if it doesn't get into a full perfect bite, I still like it there for the structure. Mm-hmm. It still holds the structure of the jaw. So I prefer to keep them if there's room. If there's even one problem with them, I have no problem saying goodbye.
Right. So it's a maintenance issue. If you can keep them clean adequately, routinely, keep them. If you can't, that's how we look at it too. I worry about people being able to actually keep it clean. And
if it's only halfway erupted and that gum tissue is never going to be able to retract away from it, no matter what you try, it's not worth it.
Right, because then you have a localized issue with the tooth and then a bacterial issue with your whole mouth.
And your heart and your body.
Exactly.
So we don't want that either. So that's how we weigh our options.
I think about patients who have not had orthodontic treatment or recently, or they're adults and it's not on their radar, and then they lose a tooth. So Mark and I are talking about this in our practice, what we do about these patients. They lose a tooth or some teeth and they get dental implants. And then what? So we can all see, as time progresses, a patient who has had a dental implant, the dental implant doesn't move because of the way it's into the bone. It's not dynamically attached to a ligament with the same type of osteoclast and osteoblast formation around them. So teeth end up moving dynamically and the implant is somewhat static in the location. So my question is, do you think that every patient who has had a dental implant should be also put in some type of retention?
That's very interesting. We've never talked about that before.
Something Mark
No.
and I are considering.
Yeah, I no, from an orthodontic point of view, I don't, but maybe yes, from a clenching and grinding point of view, maybe some kind of thing that you make them to prevent the clenching and grinding, which would cause the migration of things around it. But I don't think, like, from an orthodontic standpoint, we've seen patients that we don't do anything on and just watch over years with implants all the time, and nothing untoward really seems to happen related to the implant being static. But I think from clenching and grinding, definitely.
Yeah, what we're getting is we think that posterior implants probably not, but anterior implants maybe.
That could be. And there's so many aspects to that in terms of vertical problems as well. I have to say something about you that I always knew how knowledgeable you are. You're very, very smart. But now I see something different, which is when we're talking and something is said, like a concept, I see you thinking. Did anyone ever tell you this before? It's crazy. Like you're looking, and then you have something comes to you and you're thinking, and it's like you can actually see your wheels turning.
I can't hide anything.
It's
I'm horrible at poker.
No, but you're so smart, and I
don't know.
see the process. I'm telling you, Rob, I've known you for years.
Yeah.
It's like I watch your brain incorporating. It's crazy.
Thanks.
Yeah.
Well, I think that's we're running out of time for today. Thank you for spending time.
I loved it.
If anyone needs to find you, look you up. Lemchen Salzer
Yes,
Orthodontics.
it's Lemchen Salzer Ortho,
Yeah.
and I'm on Instagram, of course, at Dr. Salzer.
Yeah.
Yeah, lots
Great.
of cases on there that talked about exactly what we covered.
Well, thank you so much for your time.
Thanks, Rob.
Yeah. Talk to you soon.
Love you.
See ya. Love you too. Thank you for joining us this week. I hope you found it helpful and enjoyable. Please head to our website for our show notes and more information around the topics we discussed today. Please check us out on our YouTube, Instagram, and TikTok pages for weekly updates and other interesting topics we discuss more frequently. The information provided in this podcast is for general information and educational purposes only and is not a substitute for professional advice. Accordingly, before taking any actions based on such information, we encourage you to consult with the appropriate professionals. We do not provide any medical nor health advice. You should seek the full diagnosis and treatment from your healthcare providers for any issues or conditions you may have. No doctor and patient relationship is formed. The use or reliance of any information used from this podcast is solely at your own risk. This podcast is purely for educational and informative purposes only.